Well, this implant is being created for people that have lost the distal radial joint because of trauma, because of congenital deformities, because of all sorts of arthritis that could be post-traumatic, degenerative, or rheumatoid arthritis, and for people who have tumor, like a giant cell tumor that have been resected and need to have the distal radial joint working. The indication are for people that have good bone quality, that have no systemic diseases or infection, and that need a forearm to work, because to get dressed, to eat, to bathe, you need to have the hand to be able to pronate and supinate and grip and lift. And if you need to pull the cover at night, you need to do that by the ulna flexing the elbow and putting things up. So the distal radial joint is extremely important. We have had the opportunity to create this device, and I'm going to give you a little bit presentation of how things work. The radius and ulna are connected at both ends by bicondylar tipper joint. Similar to the knee, but different than the knee, each bone have a condyle at one of the ends. The radius and the ulna form the radio-ulnar joint. It's a single joint divided into proximal and distal half. Unfortunately, the orthopedic world have hand surgeon working from mid-forearm distally to the hand, and elbow and shoulder surgeon working up. And that is a problem for many surgeons to understand the radio-ulnar joint. The other problem we have is that in the literature, we have that there are 3 elbow flexors, but that's not true, because the bicep, as you can see, is a supinator, while the brachioradialis is no voluntary muscle that responds to mechanoreceptors, and the brachialis anterior is the only muscle that flexes the elbow all the time. This muscle is inserted distal the coronoid process of the ulna, and together with the tricep, the ulna goes up and down, and take with it the radius and the hand. The radius put the hand in functional position because can pronate and supinate, and that allows the hand to write or to receive money. The only problem we have that people do not recognize is taking the ulnar head out. We leave the patient with the radius falling to the stump of the ulna. That is why all those procedures that excise the head of the ulna are wrong. And not many people talk about that. They say, well, do the Dirac procedure or the Sobekapanje. Two surgery that really are made stupid because people don't understand the function of the forearm. The easy way to find out if you have an impingement is have the patient lifting some weight, 2 to 5 pounds, with the elbow in 90 degrees, the cassette between the body and the arm, and the X-ray beam horizontally passing through there. And you are going to see that Sobekapanje to the left. Doesn't matter what you do, they touch, and the end of the ulna start to look like a pencil tip because the radius rotate around it. On the right, you have a Dirac procedure with tendon stabilization of the stump of the ulna, which is crazy. The ulna support the radius. If you take tendon from the hand to support the ulna, it's crazy. Then you have a wide excision of the ulna. It doesn't matter. The ulna is going to support the radius. Doesn't matter how much you cut out of it. So how things came about? We were lucky that in 1987 we were on call, and the patient arrived with a abortion injury from a coal mine injury, and we managed to shorten the radius and put a plate, but the ulna was missing too much bone, and we didn't want to lose the function of it, so we put a stymon pin. And told the patient that if the hand will have some function and we survive, we will do a bone graft there. The patient said, no, I don't need that. I can pronate, supinate, and do everything. So, in 1992, we have a piano player that couldn't do anything because he had a Sobekapanje procedure. And he couldn't play the piano any longer. So we explained to him what we had done before, that we could put an alignment pin there, and that's what we did. As you can see proximally, we put a screw there. Well, the patient was extremely happy, disappeared, and almost a year later came back, and him and his wife were arguing. I said, what is going on? And she said, no, you ask him to tell you. She said, shut up, it's my arm. I said, no, you tell me what he's going to say. The wife said, Dr. Scheker, you told him that he was for playing the piano. He was not playing the piano. He was lifting the piano as well with his friend to move the piano. And what happened is we have now a big cavity. Look how the pin moved toward the radius. It created a big cavity. Well, being so eager to do something, I asked one of my patients to make a little ball with the Allen screw, and trying to introduce this little thing there. You see the ball? Well, I measure only the AP, the anterior-posterior diameter, because I couldn't see the defect in the lateral view because of the radius. So I'm trying to introduce the ball, and the shell crack. So I asked the nurse to get me a plate, and I bent the plate and put the stem through the last hole, put 3 screws there, and the patient was happy, clickety-clack, but he was happy because there was no instability and no pain there. Then came, in 1995, a veteran from the Korean and Vietnam War. In the Vietnam, he had a hand grenade that badly damaged the arm. He had multiple procedures, came to see me in this condition and asked me what can I do, because the only thing he can do was to get the hand going up and down. Well, we explained to him that what we had done, and that we thought that we could make a box with a plate, and in the box put a ball that will allow a stem to migrate, so the radius might have migration. And he agreed. So we have to ask the institutional review board, and took me 2 years to convince them that will work, because they say, this is a constraining implant that's not going to work. Well, it did. And the only problem was the patient came back cutting this trunk and lifting it with my implant. I said, you cannot do that. He said, Doc, it's not important to lift. What is important, I can shave with my right hand. I can drink from a glass, and I can rotate a doorknob. And that rang a bell, and I decided to go ahead and do some other patient, and they all have great result. So that's in a not what we did. This is an implant now, a plate that replaces the function of sigmoid arch, and a stem at the ball that replaces the function of the head of the ulna, and a cover with a screw that replaces the function of the triangular fibrocartilage. And the important thing about this implant is that have intrinsic stability, have full pronation supination, normal radial migration, variable angle of rotation to allow the radius to go all the way over the ulna, and weightlifting capacity. So this is the assembled implant, and this has been used in cases that nothing else could have been done, like in this patient who had a single bone forearm, because everything that was done for her would not work. She came because of severe shoulder pain. Well, she was missing everything. We undid the fusion, put an implant, and like magic, the pain in the shoulder disappeared, because now she didn't have to overuse the shoulder. We have patients who have had a so-called Achilles tendon interposition that have no work, and in those cases, we have been able to put an implant. As you can see initially how the ulna was, and look at the end how it looked like a pencil tip. And we put the stem between, put a plate between the bone anchors and the stem in the ulna, and then 2 weeks later she had full pronation supination, and after 6 months she was the happiest individual, because she could go back to sport. She plays golf, she plays tennis, she does everything. And we have patients with wide excision of the ulna, and in those cases, these patients started with just direct procedure, and they kept fusing in because they have no idea where the pain was coming from. But the pain was coming from there, from impingement between the radius and the ulna, the radius is going to follow the ulna regardless. So we had to make a special stem for him, and this is the patient now able to lift weight, pronation, supination neutral, and able to return to work. Finally, we have patients that have come to see us with the so-called von Jackson syndrome, and the von Jackson syndrome come because the carpus and the radius fight each other. And when the carpus win, the sigmoid notch disappears. As the sigmoid disappears, there is no support from the radius falls palmally, and then the ulnar head, denuded from cartilage, is grinding against the extensor tendon. And that's the first finger to go down is the small finger, then the ring finger, and so on. And in this case, the only thing we need to do is to stabilize the radius with an implant, reconstruct the extensor tendon, put the patient in extensor rigor the day after surgery, and allow her to move. And after that, she had full range of motion and able to go back to work and do everything. So why this unipolar implant failed? Because there is no way you can suture the triangular fibrocartilage to metal, plastic, or anything there. They have a very short and narrow stem, and they have windshield wiper for the stem. And secondly, like it was done in the Austin Moore prosthesis for the hip, metal rubbing against bone will erode the bone. So with this, you have an idea of how things work for this implant. The difference is when you come with fresh tissue, nobody has been there, lifting plane is so beautiful. Indeed, this is the incision. This patient had not been operated before, but she has arthritis. So you can see the plane, you elevate the skin, there's beautiful tissue there. You create a flap, you elevate a flap, and that's why young people don't understand how easy it is to create to that area. And then you put retractor on the muscle, and you can see there is the arteries and nerve that we don't need, because the posterior interosseous nerve and the artery we want to calculate the branches, and then we can continue and find out where the ulna is. We take the ulna that is affected by arthritis. We show the radius. So it's only for you to see how simple it is doing an implant where there is nothing there before. And those patients do very well because we can find the tissue and protect everything, and only one procedure, everything done. X-ray is important all the time, because if you don't have an X-ray, you might not be in the right direction, the right plane. So I'm just going to go fast how everything is done, and then at the end you have the implant, close the skin, and that's it. So for young people, that's what they need to know, how this thing is done without the need to panic, but need to keep the plane in the right position. The best thing is to see some of the videos that are in the web page, because it shows you how to do the approach. This approach has been created since the 90s, so have been proven, and if you follow step by step, then it's very simple. It's just to know the anatomy and to know the approach, and to be able to lift things without cutting anywhere, just creating plane. For that reason, it's important, if you have someone with any one of the conditions I mentioned before, any kind of arthritis, any type of tumor, rather than doing a direct procedure or the crazy Sobeka-Pangi, then what we need to do is to do primarily when all the tissue are fresh, and the patient has just one procedure rather than multiple procedures with a lot of scarring. But the other thing is you are dependent of a C-arm. A C-arm, an X-ray, to be able to see everything, because especially position of the implant. You're going to see the position of the implant by taking AP and the true lateral. It's going to tell you if the plate is the right position. Then you need to be able to drill and make sure that you have the drill bit taking the whole marrow cavity, so it's press fit, and have the reamer to do the shape of the stem in that position. So I would recommend seeing the information that is in the web page, because it tells you absolutely everything how should be done and when to check for everything. We don't want to have screws that are too long, because it's going to irritate the extensor tendon in the first compartment and even the sensory nerve or the sensory radial nerve in that area. So seeing that like that is important to have before you put the cover and you finish the implantation. Check the screw, check the position of everything. We have had the opportunity to operate on policemen, army, active army soldiers, farmers. We have people playing golf. So men have more demand of the hand than female, but it works with everybody. The only thing you need to tell those individuals, you need to take it a little bit easier, and don't be lifting 100-pound hay baler or being doing the hand or hammering a lot, because the implant is only to save the pain and keep the function of the forearm. Unfortunately, we have one implant, and we had to have the same department that Johnson & Johnson and Scheker. We had every single department for only one implant. So all those costs and insurance and everything go to that. So there are countries that unfortunately cannot afford it. We will try to make it affordable to everybody, but with just one implant and not being used so often, because many surgeons don't understand it. And I am afraid they see the images and say, "Oh my Lord, how did they get in that place?" So that's why I think it's important to follow the steps, because it's it's a piece of cake. If you know what you are doing, it's like everything in the world. Things, if you try to dance ballet and you never been in a class, so you're going to have problem. But if you have been in the ballet class, then even a male can do it.